Thanks everyone for joining this morning. Welcome to our, believe it's our fifth meeting of the Investment and Payment Work Groups. Gone by really quickly. I will bring up our meeting slides and we'll walk through the agenda to start. And while I'm doing this, feel free to please introduce yourself. Let us know you're here. So we and introduce yourself, including your name and your title, and we'd love to just track who's here and get to make sure folks are online. So again, everyone, welcome. My name is Margareta Brandt. I'm the Assistant Deputy Director for the Health System Performance Branch at the Office of Healthcare Affordability. Thanks so much for joining this morning. We are excited for today's discussion, again, on alternative payment model standards, goals, and definitions. And as I mentioned, please let us know you're here by putting your name, title, and organization in the chat. And of course, joining me this morning are team members from the Office of Healthcare Affordability and our partners at Friedman Healthcare. Excuse me. So today for our agenda, we'll begin by reviewing the feedback that you all provided on the draft alternative payment model standards and implementation guidance. And then we'll dive into our main topic, which is discussing the trade-offs of approaches to APM goals and definitions. And we'll spend most of our meeting time there and really want to kind of pause and open up for a discussion on each key decision item related to APM goals. And just again, a quick reminder of our meeting format, and just a note, we've updated this slide to include a link to the work group charter, so it's easy to reference if helpful or if needed. And as always, a reminder that we really appreciate all your comments during the chat during these meetings. We take note of them, we track them, and we use them to inform our work going forward and adjust our materials. So getting into our first agenda item today, which is the feedback on the alternative payment model standards and implementation guidance that we released for your feedback in late September. And we'll walk through the themes that we heard in reviewing the feedback. We won't get into like very specific details, but really wanted to focus on the high-level themes and bring them back to the work group for discussion and get your input on the best ways to incorporate these themes into the revised standards. So before we jump into the feedback that we received, I wanted to start with a refresher on our approach to the standards and the implementation guidance for alternative payment models. So the standards and the implementation guidance really aim to serve as best practices to approach contracting decisions between different healthcare entities, so potentially between a health plan and a provider organization, that are common across alternative payment models. And note that the purpose is not to develop a new alternative payment model, but really encourage alignment across the alternative payment models that are being used now. And also want to note that while we hope and expect that the standards and implementation guidance will be used broadly by different healthcare entities, we don't have authority to enforce the standards. That's why we've really focused on our vision for standard success, which I'll walk through in the next slide. So just wanted to kind of start with that, those reminders and grounding. So again, as I mentioned, although we don't have enforcement authority for the standards, we really are committed to ensuring that the standards are useful and support further APM adoption and really get us to this long-term goal of improvement on measures of quality, health equity, and affordability. So in terms of our vision for how the standards can be successful, our first milestone is to focus on endorsement, and that we collectively and across the industry commit to using the standards to guide contracting efforts. And then as the standards are used more we're hoping that APMs become more aligned, which makes standardization, and that standardization makes participation easier for providers. And then barriers to APM adoption increase, which then hopefully leads to overall performance improving in terms of higher quality healthcare, more equitable healthcare, and more affordable healthcare. So these are really kind of our vision and our approach to the standards as reminders. And also as a reminder, these are the 10 standards that we sent out for your feedback in late September. These have not been updated based on any of your feedback. These are, again, just reference for your for our discussion today. And then, of course, if helpful, and, it might be helpful to bring up the standards if you have them to reference, or can look back to this slide if you have it open separately as we look to discuss the feedback that we received. So starting with some generally positive feedback, we've received lots of feedback from members that they thought the standards were helpful and important and really made significant strides in getting towards more consistent, standardized, aspirational alternative payment model approaches, and that they resonated and were consistent with previous recommendations that we've discussed in the work group. We saw lots of support in the comments for alternative payment models that are budget-based and linked to quality. Also support for aligning on APM model design and performance measures to accelerate adoption and reduce provider burden. And really, again, support and emphasis on improving the collection of demographic data and to use that demographic data to adjust payments and address health disparities. And then also support for alternative payment models that recognize and reward the role of multidisciplinary primary care teams in improving value. So those kind of, to start, were some of the positive feedback and the kind of the reinforcing feedback that we saw for some of the standards. And then getting into this next slide, we had several suggestions from stakeholders on where we could add to the standards or where we could adjust the standards, and wanted to walk through those. So we heard from a few stakeholders that they would like to include pay for performance category type payments as a recommended payment model. So that would be adding to our standard that is focused on prospective payment. So that's a potential addition that we wanted to discuss with the group. Some stakeholders also suggested that measure sets should really recognize the population served by providers or health plans, and differences between serving those populations, for example, children versus adults, and that measure sets should also really focus on outcomes and getting to outcomes. And then also heard several folks share the importance and emphasize the importance of using APMs or having APMs facilitate data exchange across providers, health plans, and community-based organizations in order to equip providers with actionable data. So I'll review one more slide of feedback, and then we'll come back to both this slide and the next slide to get your reactions and discussion. So on this next slide, we have a few areas where folks thought the standards could be strengthened or improved. And there are kind of 5 key areas or key themes that we saw here. So several stakeholders recommended that the efficiency and cost savings generated through alternative payment models should lead to lower cost for consumers and decreased barriers to care. And there's, several proposed ways that we could track that and think about that. We also saw that stakeholders and folks mentioned that OHCA should more clearly state the need to promote upstream intervention and prevention through payment models and really think differently about how we are paying for healthcare and focus more on that upstream impact, or moving upstream to improve health outcomes. Other stakeholders emphasized the need for increasing investment in primary care continuity, integrated behavioral health, and care coordination, that these are really areas that are proven to have an impact in health outcomes and should be emphasized more. And then also we also had folks think about or express interest in thinking about the relationship between alternative payment models and facilitating equitable access to a more diverse and sustainable workforce. And then one of the last things we wanted to bring up was that folks also noted that more focused, tailored engagement will be required to achieve APM adoption across providers and populations. So really thinking about how do we really engage those small providers or providers who are unable to take on risk in terms of like shared savings or other types of arrangements. So those are some of the key overarching themes that we as we're reviewing all of the feedback that we received, that we pulled out. Of course, we also received specific suggestions for editing or rephrasing, and we're reviewing and considering those alongside these overarching themes. So now that we've walked through these two themes, I wanted to go back to slide 9 and open it up for questions and discussion and reactions. Kind of what are folks' reactions to these suggested additions to the standards, and anything folks wanted to add or raise related to pay for performance, measure sets, and data exchange. And it looks like, Ash, you have your hand raised.
Thanks, Margaret. I just wanted to get a comment in really quick before I can't speak anymore, so apologies. So just to give a little bit more background on the Category 2C inclusion, our comment on that was to support inclusion of this, especially for uptake of APMs, because it would encompass a lot of the state-directed payments from MCPs to health systems and value-based payment programs that DHCS currently supports, like QIP or EPP, and many other value-based programs that will be tied to quality performance, at least as a stepping stone. Obviously could be the goal to eventually get to Category 3 and 4 APMs, but for initial uptake, that was just to add some background.
Thank you, Ash. Yeah, I appreciate the context. And I think I saw Joe, your hand raised next.
Yeah, thank you, Joe. Excuse me, Joe Castiglione, Blue Shield of California. I just want to echo support for Ash's comments, and also add context, which is related to a comment I made last month, which is that it is currently our understanding that it is not possible to do population-based payment for self-funded, for certain types of self-funded products. And so HCP Category 2C is really the best that we can do, again, given what our understanding of our regulatory barriers. So we do want to support inclusion of this, and then also just want to comment that we would also support the other two items here related to measure sets tailored to populations, and then also the importance of equipping providers with actionable data.
Thank you, Joe. And so just to confirm, so in the self-insured market, you don't feel that it's feasible to move towards like shared savings or shared risk models?
That's possible, but we believe that it's possible. What we're trying to understand, we don't think that it's possible to shared savings we can use, yes, but in terms of driving toward population-based payment, which is really what we're trying to do for most of our primary care network, we're not, again, given our understanding of current regulatory limitations, we don't feel that we're allowed to do that. So we're trying to get clarity from our regulators on this. But again, I just want to call that out, that given this limitation that we believe is there, HCP land category 2C is really the best that we think we can do.
Okay, that's helpful, and we are definitely, we in no way intend to kind of override or supersede any regulatory guidance. So, yes, definitely want to be cautious and aware of that. Thank you. And I think next I saw Carrie raise your hand. Go ahead, Carrie.
Yeah, hi, Margaretta. Just want to do a +1. Notwithstanding the previous comments on measure sets focused on outcomes and populations served. And I think we had also discussed at the last meeting, thinking about social determinants of health and health-related social needs data. So I just wanted to call that out because I didn't see that in the comments. And then also, want a +1 on cost savings leading to lower costs for consumers, investments in primary care, behavioral health, and care coordination, and also the focus on, encouraging a diverse, sustainable workforce, and really that team-based approach to care that includes community health workers and other, peer support specialists, other workers as well. So just +1 for those, and wanted to call out the health-related social needs. Thanks.
Thank you, Carrie. Yes, I think we can look back on it, but I think we have, touched on health-related social needs in some of our implementation guidance, but we'll revisit that and make sure that it's emphasized, and appreciate your weighing in on the other areas as well. Before I move on to the next slide and again get your reactions or recommendations there, anything else folks wanted to discuss related to pay for performance, measure sets, data exchange?
Margaretta, this is Carrie again, and I don't know if Beth wants to comment, but I know she's on the phone, so I'm not sure if there are folks on the phone that can't raise their hands.
Oh, I know that's a little tricky, but maybe, I guess, Non or Julia, if you could try to unmute Beth, that would be helpful, or let us know how we can do that on the phone.
I believe they should have the option now to unmute.
Okay.
But if they do not, let me know.
Okay. Thanks for flagging, Carrie.
Hi.
Oh, yeah, Beth, I think, is that you?
Hi, it's Beth Capel for Health Access. Sorry for my challenges with Teams. Thank you, Carrie, and thank you, Margaretta, and thank you all for bearing with my technical difficulties. I just wanted to say that from the perspective of Health Access, what someone referred to as regulatory barriers are what we call consumer protections. Some of us lived through the experience of the 1990s when physician groups took risk without adequate regulation and without adequate financial solvency. And the result was bad for consumers as well as not very good for the physicians who found themselves with more risk than they were structured to bear. So from our perspective, those are consumer protections and they're important ones. And we appreciate that the Office of Healthcare Affordability does not have the authority to overrule existing California law on those consumer protections. So just, a lot of this discussion is about how we frame the world that we're going towards, and we support moving towards population-based payment, but in a context that protects consumers. Thank you.
Thanks, Beth. Anything else folks wanted to raise or react to on these three pieces? Okay. So it sounds like, maybe haven't heard any objections to these three areas. So these are three areas that OHCA should consider incorporating or adding into the APM standards. Any other feedback that we haven't heard yet? Yeah, Mary Jo, did you?
Margaret, I know that we also received a lot of support for limiting to category 3 and 4, at least in the written comments. So I'm wondering, no pressure, but if anyone who shared that feedback in their written comments wanted to share that here, very welcome.
Okay. Well, yeah, this is definitely something OHCA will need to kind of take back and consider as we're very much interested in moving towards more population-based payments that really promote that prospective payment and provide upfront resources for care. So it's definitely something we'll need to take back and consider and weigh the different perspectives that we've heard. So moving on to this next slide, in slide 10, on really areas we could strengthen or enhance. And before I do that, Mohit, did you want to jump in?
Sure. Thank you, Margaret. I just wanted to raise, as we're looking at standards, and first of all, I completely agree with that prospective payment point that was made earlier. It's something that we feel pretty strongly about as well, given how programming is actually structured today. But I do understand, and from other discussions with your team as well, that this is all going to be built over time, and we want to get it right, and I appreciate that as well. One of the most critical pieces that we're having as we look at standards is that so much of this is related to stratification, and so much of this is related to race, ethnicity, language, SOGI data being made available for these types of programs to be able to target the right populations in the right geographies. And one of the things that we come up against all the time is that while there are many ways of imputing REL data today, when you're creating standards around how these programs must be targeted, it becomes very important to have a single source of truth, or at least a source of truth on REL data. And that's something I just feel that we need to grapple with, because as you recognize, while some of this data is available, Covered California requires the collection of it during application processes, as does the Medi-Cal system. One of the issues that we face is that the vast majority of the employer groups don't share this data. And we really need to think through that before we start agreeing that there are APM standards that will be based on specific targeted work that must happen for specific targeted groups in order to improve equity. I just think it puts everybody in a very weird position working on a half a data set, if you will. Even with imputation, it becomes very difficult to say, okay, this is the population that I'm dealing with, and this is the programming that will work, if I don't have a clear picture of who the people actually are. And of course, there's so many other issues with REL data where people might choose not to submit it at all, even if you're asking them directly, or even if you're getting it from provider groups that do observed REL data. So just want to put that out there, that we are trying to build a system that is more equitable, but we might have a lag in the data that's available. Just to think about how we're going to solve that. Is there a way to get employers to share that data? Can they do that legally today? Would there have to be a bill passed in California to do that? I just don't know enough about the machination, but I didn't want to get too into the standards without recognizing that in order to have relevant standards, you have to have relevant data to back it up. So sorry about interrupting your flow here.
No, that's okay. Appreciate you sharing. I think I'll just note that I think part of our emphasis in the standards is that there should be a collective industry effort to determine the best way to collect this data and to determine, standards for collecting this data, and that it's really a collective kind of industry-wide effort that's needed in order to better collect demographic data and have a standardized approach across the different kind of demographic data factors that we're collecting, but that it's a really important concept or necessary part of data needed to support, addressing health disparities and addressing inequities. So I think it's not that we're, saying that the problem of data collection has already been solved. It's that we need to work collectively to enhance the way that we're collecting this data in a standardized manner.
Right, I totally agree. I'm just saying that we might have some legal barriers that we might have to address given the current federal and state laws in terms of whether employers can share EEOC related information for purposes other than employment. But, it's something we have to consider, because if that's the source of truth and we can't access that source of truth, then it's all imputation.
Yeah, and I think our general recommendation, or what we've flagged in the standards, would be for the use of self-reported data by the consumer or by the patient, and the more that we can work that into the flow of patient care, that's probably that's the best source of truth in terms of self-reported data. But we can definitely take that back and think about more of the legal ramifications or the legal construct that we're working under. Just wanted to spend maybe like 5 minutes more on this slide and get your all reaction or feedback to these 5 areas, and whether anyone wanted to kind of emphasize or react to any of the recommendations here to emphasize or adjust the standards. Yes, Reshma.
So this is one that I kind of struggle with, and I think, and so I don't have the solution, but I just wanted to voice it, because I think there's a lot of creative minds on the call here. And I know the last couple drafts, I sent a lot of comments over to you, Margarita, so sorry for the long emails, but one of the things I struggle with is just this issue that when I read the document of recommendations, it does very much sound like we're focused on low value care reduction and total cost of care reduction. There's a mention straight out that gets called out around consumer costs directly. But I think that in itself shows that when you talk about kind of connecting this to actual APMs, how much of an emphasis are the APMs going to actually have on the consumer out-of-pocket data? And also around, what that means and that translation into actually getting those costs down. And a lot of that's going to end up being contracting between payer entities and kind of health systems. And so what we're creating doesn't have control as much down to that level of contracting and kind of getting into the nitty gritty. So that's why I struggle. But at the same time, if our document doesn't emphasize it and call it out enough, I think it's really easy for me to read this. Let's say I was not in this group and I'm just reading it, to glaze over that. And so I don't know exactly how to bridge that with kind of what we're creating, what we're allotted to create. I think the other piece of it, though, is that a lot of folks don't have an idea of where those opportunities are. I think there might be some on kind of the payer side, but the health system side, I think there's a lot of gaps in having a vision for where those are. And so I feel like unless both parties in that negotiation kind of discussions are prioritizing that, we're not going to see as much change in that outcome. And so this is an opportunity, I think, for California to take a bolder stand on trying to move that outcome. But how do we do that? You know, so I'm leaving you a question that I started with as well. But I just could easily see this coming through with an impact on some of what we've seen from other states and some level of change around investment for primary care, behavioral health, and even low value care to some level. But without really calling out that consumer part, it's a tough one, and there's a reason why we haven't seen much movement on it out of pockets here and there. And so I just wanted to pose that question to the group.
And Reshma, are you really thinking through like the connection between the implementation of an alternative payment model and over time decreasing consumer out-of-pocket costs?
Yeah, because I think the thing is people will say, they'll read this and it's like, where are the focus around interventions, right? So there's negotiation around certain things, but the story of patient out-of-pocket costs or consumer costs is sometimes very different and there historically has sometimes been opposing the reduction around total costs. So example, the history of observation stays and reimbursements. Sometimes I got shifted over to patients, right? And so I just think that, you know, times have changed, and then in different payers and kind of what they contract with different groups, health systems is different. So we're not in a position to micromanage that, nor can we get into all the details to say, you know, here are the 20 most common opportunities for out-of-pocket costs. So have a vision on this as you're discussing your negotiation. I mean, that's all I could think of, and that seems very prescriptive and very a little bit micromanaging. So I don't know where that balance sits, but I still feel like it could be glazed over pretty easily, and we won't change the outcome. That's my concern.
Thank you. Any folks have reactions to that or thoughts?
I think the best advice I would hope to seek would actually be on the payer side around that. But yeah, any thoughts on that one?
Hi, it's Beth with Health Access. Can folks hear me?
Yes.
Yep.
Okay, thanks. Two thoughts, and we raised the same question in our comments. One of the things that Covered California has done very well is to structure benefit design in a way to prioritize primary care, which goes along with their contracting provisions. And they have also looked at attempting to structure cost sharing, and benefit design here really means cost sharing, attempting to both structure cost sharing to prioritize primary care and generic drugs. They haven't gotten much beyond that in terms of low value care, but clearly benefit design is one of the levers that payers have, and that goes hand in hand with the discussions we're having about primary care and alternative payment models, and eventually we'll get to behavioral health. I think the other thing, and this is stepping back, those of us who helped create the Office of Healthcare Affordability really had a vision. There's a reason why primary care and alternative payment models and behavioral health are in the same law with the spending targets. It is that over time, we will actually do system transformation in a way that, you know, the California version of the triple aim actually comes to be, that we lower costs while improving outcomes and improving health equity. So I think it's the right question to ask, and I think it's a question we should keep asking. Part of our frustration from the consumer side is a lot of times we see efforts at delivery system change that don't move things forward from the perspective of the consumer. And any savings that are accrued in one part of the healthcare system just get eaten up in this big, complicated industry that so many of you spend your careers working in, and consumers don't see the benefit. So I promise you Health Access will keep asking that question. We may not always have an answer, but I promise you we will keep asking, and we appreciate others asking as well. Thank you.
Thanks, Beth. Monica, did you want to jump in?
Yeah, I don't have any answers to those excellent questions raised by Beth and Reshma, but I do think, we have learned even from things like the oncology care model, right, that you really do have to think on like, what are the actual drivers of costs? Be pretty explicit about where is their low value care occurring, and then to everyone's point here, think about the true redistribution from here to there. And so it does feel like that level of granularity is necessary, or at least the focus on we're being very crystal clear. Where are the drivers, right? What are we trying to do less of to get them more of? And so it feels like we could actually strengthen that a bit more, at least as a stepping stone to what you described of the redistribution.
Reshma, and then Catherine, I didn't know if you still wanted to make a comment.
I'll be really quick. This is just in response to the last two. Yeah, I echo that feeling too. I think there's a great opportunity again for California to do something a bit different around this than other states have jumped in. And I'm going to share something in the chat, but it's got a different lens on it. So I want everyone to kind of have a view of that we have to do something a little bit different. But to Monica's point, I think knowing where the drivers, I think that was actually, Monica, your first point in the first meeting as well. But it's one of those things where I know there's a separate data team. And so like, we may not have vision on it, but then, HCA actually does have vision on it of what some of that data is available, but it is at that kind of payer kind of health system level. And where those opportunities get defined, I think there's a lot out there about where to look around low value care. There's not a lot out there about where to look for out-of-pocket costs. And again, I think that contracted in kind of that, as we said, kind of that shared work that folks are doing now to kind of do shared benefit design and things of that sort, I think really help. But there's still a gap on all sides around where the opportunities are. So I'm going to share a link where some of that happens, but it's coming from a health system perspective. And I think there's a lot more opportunities actually with that shared benefit design that are not in this, but I do want to share that with you all.
Great, thank you. And Catherine.
Sure, thanks, Margaretta. So really appreciate the conversation from Beth and Risha and others on equity in benefit design. There are many recommendations out there, namely to income adjust premiums. I hadn't thought coming into this that benefit design was under the purview of this work group. Very exciting if it is, but just wanted to take a moment and sort of clarify, are we talking about benefit design as a component of APM? Is benefit design under OHCA somewhere else? Before we get too deep and too much excitement going around how to think about structuring that in a way that's effective and supportive for consumers and particularly low-income consumers.
Yeah, really good question. I think we had, not been focused on addressing benefit design specifically, and that hadn't felt that was part of, our overarching, mandate. But I think it's something to consider in terms of if these are APMs and intended to be used by purchasers, payers, and healthcare systems, healthcare organizations, that we can think about what's the relationship and how might we encourage, especially purchasers and payers, to think about benefit design tied to APMs. But I think we still have a little bit of thinking to do in terms of the relationship and how we might emphasize that here.
Okay, thank you.
Hi, it's Beth again, if you can still hear me.
Yes.
There is a feedback loop between the office and the rate review that's conducted for state regulated coverage, which is, after all, in California, 3/4 of commercial insurance. So it would be possible, for example, and I'm going to use primary care as the simple example, to suggest that they look for lower cost sharing for access to primary care and generic drugs as features of benefit design as part of the rate review process. It's a little harder to get to something we like very much, but the scaling share of premium to income because of ERISA. And there are probably some things I'm not thinking of in the moment, but I think there are perhaps more opportunities than are obvious on the face. And so the virtue of a work group like this is we think of ideas. So thank you.
Yep. Thanks, Beth. So just to, for the sake of time and to make sure that we have enough time to kind of have detailed discussion on setting alternative payment model goals, I think we should probably move on, but of course this is not, the last chance for feedback or discussion. Please feel free to send additional feedback via email to me, and we will continue this discussion again in November and bring something back to you. So moving on to discussing the approach to alternative payment model adoption goals and definitions. Again, here just wanted to start with a brief refresher on our approach to developing goals and definitions, and re-emphasize that the purpose of the goals is really to promote the shift from fee-for-service based payments to alternative payment models and better align financial incentives for equitable, high quality, cost-efficient care. And kind of as we've discussed in previous meetings, we will use the Healthcare Payment Learning and Action Network, or HCP LAN framework, to monitor our progress towards increased adoption of APMs. And again, noting that while OHCA doesn't necessarily have authority to enforce the goals, that we will publicly report on our progress towards the goals and really have accountability through transparent public reporting. And again, for definitions, the purpose of the definitions is really to define what counts towards the APM adoption goals, and these definitions of collecting non-claims data and alternative payment model data are in our expanded framework for non-claims payments that we've discussed previously, and will be again crosswalked to the HCP LAN framework. And both of those frameworks are in the appendix, if helpful for reference. And I'll turn it over to Mary Jo for the next two slides to walk us through some decisions.
Thanks, Margaretta. So there are 4 strategic decisions related to developing APM adoption goals that we're going to focus on today. The first is which types of payments should count towards the APM adoption goal. The next is whether these goals should vary by payer or product type. Then there are questions related to how the goals should be structured and what metric the goals should be based on. Next slide, please. We wanted to provide you a brief example from Oregon. So Oregon has made many of these same decisions in designing its APM goals. You'll see that Oregon limits the types of payment models that count towards the goals. It uses HCP LAN 3A and higher for some, and HCP LAN 3B and higher for others. It also does not vary those goals based on payer or product type. The Oregon goals use percent of total healthcare spending as the metric that the goals are based on, and they are designed as a series of stair-step goals until 2025. So next, I'm going to turn it over to Margaretta to talk through some early draft recommendations for some of these decisions in California.
Yeah, thanks, Mary Jo. And so, in thinking about this conversation, OHCA really wanted to propose some draft recommendations for reaction as a starting point, because there's lots of decisions to be made, and this can get quite complex in thinking about all of the layers. So these are draft, recommendations for reaction. And so we're really looking to get your feedback today on these proposed recommendations. So first, starting with that first question of, should only certain types of payment models count towards the APM adoption goal? And, initially OHCA's recommendation is that category HCP LAN category 3A, which is shared savings only, and payments above that moving towards population-based payments should count towards the goal. And then the other question about whether we should require a minimum level of shared savings or shared risk. And we think, yes, that's helpful, that there is, there is an emphasis on increasing shared savings or shared risk so that there's actually an impact of those models. And then should APMs be linked to quality or not? And our perspective is yes, that alternative payment models should have a link to quality. And our next recommendation is that the APM adoption goals should not vary by payer type or product type, that we're really looking for alignment across payers and products and to have, an industry-wide goal. And in terms of the approach, the structure of the goal, we are recommending that we have a series of step goals that accumulate with an absolute goal several years in the future. And then to the question of what metric, percent of spending, percent of members should we use to monitor APM adoption? We don't have a specific recommendation yet here. It's really, pending review of data collection feasibility in terms of how we can collect this data and your feedback today. We heard different recommendations from work group members throughout, the feedback we've received offline and in our meetings on which metric to use. So these are our initial recommendations for reaction, and then in the coming slides we'll kind of walk through each of these decisions and pause for a minute or two for questions or discussion. So just wanted to frame that, and then I'll turn it back over to Mary Jo to walk us through the next set of slides.
Absolutely, thanks, Margaretta. So over the next set of slides, we're going to discuss trade-offs for each of the strategic decisions, and as Margaretta mentioned, give you a chance to weigh in as well. So nationally and in California, most APM adoption goals focus on Category 3 and Category 4 payments. So APMs built on a fee-for-service architecture. These are typically going to be your ACO-like contracts, as well as episode-based payments, and then Category 4 payments, which are those capitation and other population-based payments. The draft standards and implementation guidance recommended using these payment models whenever possible, and workgroup members generally agreed with that in their written comments back to OHCA. So this sort of leaves three questions remaining. One is whether OHCA should include HCP land Category 3A. Those are payment models with shared savings only, no downside risk. The next is whether OHCA should include Category 3 payments that must meet a minimum threshold for shared savings and risk. We'll talk more about what that can look like in a minute. And then the third question is, should OHCA include 3N and 4N payments? Those are payments that do not have a link to quality. Next slide, please. All right. So this first sort of sub-question here is going to focus in on those Category 3A models and whether or not they should count towards the adoption goal. So as we've discussed, some providers lack the financial assets and experience and willingness to take on downside risk. And we know that engaging these ACOs is important. Research finds that low revenue ACOs, which are typically physician-led, are more likely to generate savings than high revenue ACOs, and new entrants are needed to reach APM adoption goals. I'll also note that Covered California includes 3A models in its goals. On the other hand, some ACOs, particularly those led by health systems, have in the past had difficulty achieving financial success in APMs and perform better when more risk is at stake. And also HCP land does exclude 3A models in its APM adoption goals. So I'm going to take a breath there and pause. I know that we have at least one person with their hand up. Looks like Mohit.
Yes, thank you. So the team in-house here at Anthem, one of the issues that they've raised is that sometimes there's not a a cost implication to the APM model. And in category 2, under HCP land, the model might focus solely on quality improvement. But in doing quality improvement, one could make the argument that you're also, achieving long-term, better healthcare cost control, et cetera, in the system. So I just wanted to table that while, the direct relationship between cost and quality, or like upside and downside risk, is very much a part of what we all work towards. There might be arrangements that are in the field today that focus solely on quality improvement as an incentive, as opposed to, cost reduction. And I just wanted to kind of air that, because we wouldn't want to lose out on things that might be working in the field as we proceed.
All right. I don't see any other hands up at this time. Margareta, do you want me to go ahead to the next one?
Yeah, I think I'll just note that, OHCA is really interested in moving forward with, more prospective population-based payments. So thinking about, 3A and above are a way to transition us there, even though we recognize, some folks might need to start at that pay for performance level. So I think it's, in terms of the goals, I think there's a potential for folks to transition over time, but that the goals are really intended to, to set, as they are, a goal for future state. So kind of thinking about that approach, like, can we do what we're doing now in terms of 2C, or get more folks on 2C and transition to 3A and, to shared savings, shared risk, population-based payment over time. So I just flag that as a potential approach, is, that these are intended to be goals over time.
Absolutely, Margareta, and I completely appreciate that. And, just given the comments made earlier about the types of APM arrangements that might be possible given Knox-Keene and, other self-funded versus non, that would then push us towards a thought that we'd want to keep the APM models, not across the board, but maybe segment them by payer type, so that you don't get into trouble with any other legal issues, so that you can have commercial or self-funded have certain types of things, and Medi-Cal and Medicare have certain types of things that are allowable. Now, I mean, it doesn't get you all the way there, because you want to have consistency, but again, we're trying to function within the rules that we have.
Mm-hmm. Right, and would just restate from earlier that category 3 models would be included, and so that would be a pathway for those other payer types. I know we're going to talk more about product and payer variation in a couple of minutes. Margaret, it looks like we have a comment from Carrie.
Yeah, Carrie, do you want to jump in?
Yeah, I think I have a question in terms of, how our purchasers are defining their value-based payment APMs. Are, to what extent is 3A included at this point or not? I think, we would certainly like to see plans, we would like to see providers and plans moving to 3B, 4 and above. And so, I think I have some concerns about 3A, but I'd like to better understand, what is California doing? How do we ensure that we're aligning appropriately with the national standards as well?
Thanks, Carrie. And I'll just note, in terms of kind of the HCP land national goal is focused on category 3B and above, so that shared savings, shared risk. But then, there are other approaches in other states and in California. And I don't know if any folks from the California purchasers want to weigh in, you're welcome to. And Carrie, we can of course kind of think about this more and come back to it.
I think you referenced us already, Margareta, as including 3A in our 23 to 25 contract, and having people sort of march towards that.
Thanks, Monica.
CalPERS is similar. We don't have a requirement specifically for 3A or 3B, but generally reference 3 with a goal of moving towards 4.
Great. Thank you, Lisa. Okay. Mary Jo, do you want to discuss?
Yeah, this is Beth again. Just to point out that to the extent that self-insured groups use third-party administrators or ASOs that are also California licensed carriers, I think there is a path forward that is consistent with the existing regulatory structure to move towards 3B and 4. And I do say that knowing some of the barriers, some of the reasons why there are self-insured lines of business. But I think, we're balancing consumer protections in a number of different ways, trying to move forward towards a better place for consumers and purchasers. So I'm sure we'll come back to this again. Thank you.
Thanks, Beth. Go ahead, Mary Jo.
All right. So the next question relates to whether Category 3 payments should be required to meet a minimum threshold for shared risk and savings or savings to qualify towards the APM goals. So one of the things that we've seen in other states, and that some of you maybe have seen in your work, is that some Category 3 models have very limited opportunity for shared savings and or put providers at very minimal risk. And so to address this, in some other states, APM adoption goals actually specify a minimum threshold for shared savings and or downside risk in order to qualify towards the goals. And we have not yet, decided or made a recommendation on what that shared savings minimum might be. But for example, the CMS Medicare Shared Savings Program, or MSSP, that offers providers a minimum of 40% of shared savings if their quality performance and other terms are met. So why put these types of minimums in place? One, of course, meaningful accountability for cost drives improvements in value, but also meaningful accountability for shared savings will increase provider participation. And thresholds for shared savings and risk may protect against gaming. We don't want to sort of have the unintended consequence of encouraging, really minimal accountability through putting the goals in place. Reasons not to require, it may seem prescriptive to the contracting entities. Note that dollars flowing through APMs that don't meet these requirements would still be collected. They just would not count towards the goal. So I can pause there for any questions or comments.
Mary Jo, I think there's a process question in the chat.
Great question from Kevin Grumbach. Are we voting on these specific recommendations or just having an exploratory conversations? Yep, it looks like Margareta has responded. Thanks, Margareta.
Yeah, so we're open to both. So, but would encourage folks, if you have a specific opinion or reaction, we definitely want to hear that today, as that'll help us move forward.
If I may, because people have started to comment, I have some comments on others, but we're sort of going through all of them right now. Are we going to sort of at the end say, okay, last call for comments, and then we're going to vote on item 1, 2, 3, 4, or I just want to be a little clear.
Yeah, we won't do that specifically, but as we're going through them, we really welcome you all to, voice your opinion on either in the chat or verbally, whether or not you agree with the recommendation or would propose a different approach.
Okay, thanks.
Thank you.
All right, Margareta, maybe we'll do the last one then in this series, and then we can pause again for some questions and comments. So I've already seen a few comments in the chat related to this, but the last question is, should payment models be required to have a link to quality to count towards APM goals? Obviously, OHCA's goal is to promote equitable, high quality, and cost efficient APMs. OHCA could require the provider's payment to be impacted by quality performance to count towards the goal. So for example, the Integrated Healthcare Association's Align, Measure, and Perform program is one example of how a capitation payment could be linked to quality to qualify. Some of the benefits of this approach include, obviously, it recognizes the importance of maintaining or improving quality through APMs. It aligns with workgroup member input on APM standards and implementation guidance, which recommends the use of quality-linked models. And it aligns with other states and national APM adoption goals, including HCP LAN. Some reasons to consider not requiring: it may be difficult to develop a clear definition and monitor, although I think we have made some progress in thinking about that. And there is limited data available on APMs in California linked to quality today, which complicates a little bit setting those APM adoption goals initially. I'll stop there, and it looks like we have a couple of hands raised.
Yeah, Kevin, go ahead.
Thanks. So about the quality requirement, I think we need to realize so much of the way we've been talking about this is really about alternative payments going to large organizations, whether ACOs or integrated systems. And we haven't really focused much on the idea of alternative ways of directly paying providers. And I'm specifically thinking here of primary care. So I'm in favor that all payers should move towards more population-based payment, i.e. capitation for primary care, and away from fee-for-service. But I would not make that capitation linked to quality per se. I mean, we know that I think all the thrust of what we've heard so far is about how supporting primary care in and of itself is a huge policy to promote better quality and better outcomes. And a base capitation of primary care should not, in my mind, be linked to quality performance. You could have other sorts of quality performance, or quality as an entry criteria to see who's eligible for that. So I think we have to be a little careful about keeping in mind there's some other things that I would consider falling under alternative payment models that are not all about sort of large organized system bearing risk. So I would not want to say we wouldn't have standards that would include endorsing something like a direct capitation payment to primary care that's not directly tied to quality.
Just as a follow-up to that, this is Mohit. I think that's also part of the reason why we'd encourage looking at, the goals should be set more along the idea of the number of members attributed to that APM arrangement rather than the spend, because in smaller primary care practices, the membership would count towards them accruing within the APM as opposed to a total spend of our APM program writ large.
And if I can just respond to Bill's comment too, we're not talking about global cap to primary care. So it's not being at risk for specialty referrals or other costs. Again, I mean, I think we're so in that world, but if you're looking at what's happening with direct primary care, with employer direct payment to primary care, they moved to capitation models. I think there's, that's actually in the rest of the world how primary care often is paid. So it's not bearing global risk or even risk for other costs. It's just a basic way of paying for those services provided in primary care. So
I think that's a really good flag in terms of how we might think about, primary care capitation in and of itself, or, other other like narrower forms of capitation. Monica?
Yeah, maybe this is like a bridging complementary comment, which I'm thinking a little bit about the specialty perspective. And I think there are absolutely spaces where you might have something that's not connected to quality, just to be frank, right? Site of care shifts, generics, biosimilars, these are all things that actually you might want to take away perverse incentives that currently exist in our model. But I would not describe that as a quality intervention. That's clinical equivalence. I think the comment from Bill, though, is fair in those spaces, even in the specialty spaces. You want to make sure that you don't have underutilization or inappropriate utilization because of that. But that's not exactly quality, or certainly isn't quality measurement the way we often talk about it in the APM space. So a little bit of like defining what we mean by some of this, I think would be helpful in distinguishing quality from utilization. And I think there is a space where you might just fund things differently, disconnected from quality measurement or the way that AMP has done it in the past.
Yeah, so, are we thinking about a narrow definition of quality in terms of, performance on specific measure sets, or are we thinking broadly in terms of quality also tied to utilization and redistribution of care or resources, things like that? Okay. I'm not sure we're gonna maybe answer this question directly today, but it's a really helpful flag. Okay. I think for the sake of time, because I know we have a few more pieces to get through. So I'll move us on to this next question. And I think Mary Jo or Vinayak.
Sure, thanks, Margareta. So as you all might expect, commercial Medicare Advantage, traditional Medicare and Medicaid all have varying levels of APM adoption, both in California and nationally. And that's largely because there are some differences in populations, contracting challenges, and priorities all kind of contribute to that variation. The HCP LAN varies its goals by payer type. Specifically for Medicare and Medicare Advantage, they have different goals from what they have for commercial and Medicaid. So varying those goals by payer type would also kind of allow for that more ambitious goals for payers with greater adoption today, which we do see particularly in the California market and reviewed last month, for example, for Medicare Advantage. Though there are also some strong reasons to align payer type goals. It holds all payers accountable to the same goals and promotes all populations having the same access to value-based care. In some ways, it's also consistent with HCP LAN, which has the same goals for Medicaid and commercial, and then only varies for Medicare, as I just mentioned. I know that some folks were talking about payer type differences. I'm interested to hear your reactions on this.
Any kind of opposition, or anybody think, if you're open to speaking up, that we should vary goals by payer type, whereas OHCA is recommending that we do not, and we look for consistency across markets.
So I'll just echo what I said earlier. Maybe I should have waited for this slide, Margaret. But, because of the reasons, and some of the reasons are here on the right side of the chart, we've been thinking that given the current state, that it might make sense to vary by payer, just to allow for, the adoption to actually occur. But I mean, we see the point about having consistency, but then again, you've got to look at the payer type and the contract type, because even in certain areas, like when you're looking at the most vulnerable populations being served by, let's say, FQHCs on the primary care side of the house, we're currently trying to develop an APM methodology for FQHCs in California that doesn't crush their PPS payment. So if you had a consistency right now with a very low volume of voluntary adoption on the FQHC side, that's, you know, still would need to be CMS approved as not varying their PPS payment or how all that works. You wouldn't be able to just have the same programming if it wasn't blessed. That's just an example that off the top of my head, maybe I didn't explain it right, but you know, we do deal with like 15 million people who probably are the most vulnerable that need to be addressed here outside of the commercial space.
Hi, this is Beth. This is a question, not a, yeah. Is there, recognizing that different organizations, both payers and providers, start at different places, and I hadn't thought about the FQHCs and the complications with PBS, but I'm glad someone else is thinking about it because that's clearly a consideration. But thinking back to last month's presentation where HMOs are much farther along the path of APM adoption than PPOs, for reasons I think we all understand. I mean, the question that the staff are asking is, the goal, their recommendation is the goal should be the same, but I think we do need to recognize that different organizations start at different places. And so progress towards the goal may be harder or easier. And so, I mean, part of the intent here, as I understand it, is to help think through how the organizations that are farther away from what I think we all agree is a shared goal can make progress towards it, if that makes sense to others.
Yeah, so, you know, potentially focusing our efforts on where we can make the most progress or where we have the most to grow, to move towards any goal we set. Yeah. Yes.
Where we're farthest behind where we'd like to be. And that's not a negative comment. That's just we have to start from the world as it is comment.
Yep. Mm-hmm. I think, Sarah, you had your hand up.
Yeah, just a clarifying question. Are we talking about behavioral health inclusive of these overarching goals now, or is that separate and will be addressed later? Because I think the answer to your question, I don't know how I think for behavioral health would be, we have to acknowledge the different payer types, kind of back to the conversation at the beginning around the benefit packages are so different. Like I was looking at EOCs of CalPERS plans while we were doing this for behavioral health benefits, and there's such a variety there. That's not even counting the Medicare and then Medicaid or Medi-Cal.
Yeah, I think we're thinking of, you know, if from our APM standards, if one of our, you know, approaches within an APM model is to promote behavioral health integration, that, you know, thinking about behavioral health as integrated within the system and the payment model, but, you know, recognizing there's lots of challenges and or, you know, structures in place that may prevent and or make it more challenging to have like full behavioral health integration, but are thinking generally that behavioral health is part of the systems that we're talking about in terms of alternative payment model adoption. Catherine?
Sure. So I assume when you say goals vary or goals consistent, you're talking about the type and degree of APM. How are you thinking about timeline? Because flexing the timeline might allow some latitude for some payer types that are a little bit further behind, that have special challenges, but still get at the value of consistency across payer types. So I was just curious if you're asking, does the timeline need to be consistent too, if we want to go with the consistency goal or value, or is that one that we could sort of mediate or moderate, so to speak?
Yeah, no, we can definitely think about like moderating lots of different efforts in order to kind of work us towards an overarching goal. So there's I mean, yeah, there's tons of kind of ways we could moderate the
flex
goal.
it. Okay.
Yep.
Thank
And
you.
timing in terms of the structure of the goal is one of our next decision items that we'll talk through.
Okay.
And Mohit?
Hi, just going back to Sarah's BH comment, I think that's really important to note because when you look at, for example, the providers that are going to be pulled into APMs, in California for 15.5 million people, the behavioral health system, while being integrated today under CalAIM to the extent possible, is still bifurcated in general. So county behavioral health picks up a lot of SUD and severe mental illness patients as part of how we do behavioral health care in California. So are we saying then that even county-based providers would have to align to these APM goals? Again, going back to the who's involved and who's not and what timeline you can have people on, because the level of sophistication amongst the provider groups is something that we need to consider. Some of them might not even have data systems that can do APM. So, again, the timeline, the type of provider, and especially for BH, looking at the frontline BH delivery system, which is county-based for about 15.5 million people today.
Yeah, that's definitely an important consideration. I think it's something we can work with DHCS in terms of thinking through how we might approach that and what they're thinking in terms of APM adoption across Medi-Cal. So thank you for the flag, and we'll definitely be sure to follow up on that. I'll keep us moving. Vinayak, do you want to walk through this next slide?
Sure. So variation by product type is also pretty dramatic across different types, particularly in PPO and HMO plans. HMO plans being largely already within Category 4 capitation. Some of the differences in provider networks, as we've discussed quite a lot today, the regulatory requirements and purchaser preferences all contribute to that. The reasons to vary the goals include the high percentage of HMO lives and dollars in Category 4 currently. Though it's important to note that we don't actually know what percentage of those Category 4 arrangements have a link to quality. There are also regulatory requirements that limit adoption of Category 4 payments, particularly among self-insured purchasers. And similar to the payer type discussion, it would allow OHCA to set a more ambitious goal for those HMO plans. Similarly, there's also good reason to align across product types. It holds all product types accountable to the same goal and promotes all populations to have access to the same opportunity for value-based care. And then if HCP land Category 3 and 4 models both count towards the goals, all product types have a pathway to achieve the overall goal. And so here I know that there's been a little bit of discussion about this in the chat. Curious to hear from you all as to whether we're more supportive alignment here as OHCA is recommending, or if there are any thoughts on additional reasons to vary the goal by product type.
Well, I think for the sake of time, if no one has additional reactions, I know we've had some comments on this before and in previous discussions and in the chat. So I think I'll keep us moving to how the goals should be structured, which a little bit gets to the timing question that Catherine brought up earlier. Is we could add different timelines associated with the structure of the goal.
All right, so there's 3 approaches to consider, and each of these approaches can really be layered. So that's something to think about as we discuss these. The first is a stair-step goal. This essentially is a series of smaller targets that can lead to an overall improvement goal. This approach is pretty consistent with other APM goals in California and nationally, including the HCP LAN. It typically terminates with an absolute goal that offers that aspirational vision for where payment models should be. The next is the absolute goal. This is a single improvement goal. It provides that long-term aspirational vision. And the last one is a relative goal. So these goals are essentially increases relative to current performance. It meets each payer where the payer is at, and at the same time can require the same pace of progress for all payers. And it can also be helpful when data on current adoption is lacking. What it lacks is that benefit of the long-term vision of where payment models should get to. So here, interested in hearing from you all about how that goal should be structured. Catherine brought up a good point that the goal can be structured in a way that it's paced out for different payer types, depending on where they currently are with their adoption. Interested to hear some reactions to that piece as well.
And I see, Carrie, your hand raised.
Yeah, hi, hi, folks. I think, in looking at these different options, the stair-step goal seems to be, most likely to kind of move the needle and move things forward. I think I'd be concerned that, an absolute improvement goal might be too theoretical and distant. And the relative improvement goal would be too incremental and also, perpetuate differences by payers. So I think for us, we would lean towards the more of a stair-step approach, and would love to hear others' thoughts, but that's sort of our initial thinking.
Thank you. And Reshma?
Thank you. Yeah, I agree with the stair-step approach for the same reasons. The only thing I might add is there a way to add in a relative component? And again, that's coming from like certain practices that might be more vulnerable in this process, that there's some avenue to actually get, like, I think I've mentioned this before, but like a delta change of improvement. So they're still based on top of a stair-step approach, but there's just like this additional pathway to help those folks out. That would be my recommendation.
Thank you. Yeah, we can definitely think about that. Any other reactions? Okay.
Right, then I'll turn it back over to Mary Jo to talk about, I guess, what may be one of our most important questions for today.
Sure. So thanks, Vinayak. This question is focused on the metric that would be used to monitor progress towards the goals. As we noted earlier, we do not yet have a recommendation on this one. We want to hear more from all of you, from other stakeholders, and we also want to continue some conversations on data feasibility. I'm going to walk through each of these metrics and the trade-offs, and then we'll open up for feedback and questions. So the first is percent of total healthcare spending. This aligns with the Covered California collection and goals, and also HCP land, APM adoption goals. It's also probably the easiest to reach since all contract dollars, quote unquote, count. This is especially true if you're sort of engaging providers that are larger and have larger spend. On the flip side, though, there's less motivation to engage providers and members who are more difficult to engage because they often also have smaller populations and smaller spend. The next is percent of members. This is most aligned with the population health philosophy that healthcare entities are accountable for all patients, even those that don't seek care. It also promotes attribution rules that capture more patients, and it encourages engaging members who may not be the easiest to engage. We go to the next slide. We have two more here. The first is non-claims payments. This is actually the percent of the total healthcare spend paid via a non-claims payment. This promotes prospective payments and other payments that transform care. It also promotes those payments being really meaningful, right, and considerable. And however, it may be viewed as a little bit more prescriptive. And the last one is percent of providers. So the percent of providers has the potential benefit of requiring payers to engage rural and small providers who may be more difficult to engage, but it also may be difficult to measure given the amount of delegation in California. And it requires an extra data field, which is another reason that it may not be optimal. So I'll pause there for some discussion.
Thanks, Mary Jo. So reaction to folks in terms of, what we should be measuring towards APM adoption, percent of total health spending, percent of members within an APM, covered or cared for within an APM model, non-claims payments, or percent of providers. And I know this is a big question to end on, but feel free to put reactions in the chat, and then we will, I will also send out these, these key strategic decision questions we walked through today as a follow-up. And if you all have feedback you want to provide after the meeting, following the meeting in writing, that would be super helpful as well.
Margaret, it looks like we're starting to get some comments in the chat. Most supportive of percent spend, percent membership also feasible, and that's really consistent with what folks provided to us in writing prior to the meeting as well.
Can you go back one slide, please?
Yep. Mm-hmm. Thanks, Dolores. That's helpful to note. Dolores noted in the chat that IHA found that results based on percent spend and percent members were very similar, so that's helpful. So I know we have 1 minute left, and we've left you with lots of questions and requests for feedback. So I will just wrap us up, and of course send out a follow-up email and solicit any additional feedback you all have via writing. We very much appreciate all of the discussion today and all of the feedback that you provided us in writing on the APM standards. It's super helpful. And again, just really appreciative of all your engagement over the process. So we will be reviewing your feedback and revising the APM standards and implementation guidance based on the feedback we heard today and that we received previously in writing. Then we'll also take all the discussion and considerations today to draft some proposed APM goals and definitions for our work group discussion in November. And we're planning to share revised APM standards with you all in early November and bring those back to the work group in November for feedback, and then bring those and then also discuss APM goals and definitions. And then in November, we're also intending to bring draft APM standards, definition, and goals to the advisory committee for feedback and discussion. And then, of course, based on their input, we'll return to the work group to debrief. And then kind of November, December, planning to transition to focus more on primary care spend. And as a reminder, if you're interested, we have a primary care spend subgroup that's really diving deep into the details. So if you are interested in that primary care spend subgroup, please email me. And I think with that, I will wrap us up. I know we're a minute over. Thank you all so much for your time. Thank you so much for your feedback. We very much appreciate it. And we'll talk to you soon.
Thank you.
Thank you.